My talking and the slides match. Here we go. Okay, here we go. Okay, so we're going to do as much as we can in half an hour, a little bit of show and tell with the respiratory assessment. We're not going to cover everything under the sun, but we're going to try our best to cover as much as we can. Okay. So in particular, we're going to touch upon the respiratory assessment, and we're going to cover some interventions that you'll see at home: airway clearance, inhaled medication, positive airway pressure. So jumping forward to the respiratory assessment. Okay, we're going to focus on two things in particular. We're going to listen to some lung sounds today, and we're going to just define dyspnea and labored breathing. So this is an example of what you'll see on can time. So respiratory assessment. So for there is a difference between dyspnea and shortness of breath. Dyspnea is the sensation of respiratory distress. Your clients might say, I feel like I can't breathe. That would be dyspnea. Labored breathing is when you actually see the signs. So you might see abnormal respiration. You might see accessory muscles being used, retractions, nasal flaring, stridor, grunting, hyperpnea, tachypnea. It's possible you could have dyspnea without labored breathing. You could have labored breathing without dyspnea. You could have none of them. You could have both of them. So they are a little bit different. When we get to the actual lung sounds, it's important that you assess lung sounds and document every single shift. I recommend beginning and end of shift and every time there is a change of condition. If you feel you have to give a PRN med or do a PRN intervention, take the lung sounds before and after. Check if your interventions are working. Take note of the rate and pattern and any adventitious sounds. So let's get into the adventitious sounds. So you'll see the little check boxes on can time, and there is a box for rails, crackles. I just want to let you know there are different terms being used, but rails and crackles, they are indeed the same thing. And so I've always referred to it as crackles. You hear a kind of a crinkling noise as air pushes through fluid in your lungs. There is a bit of a crackling sound. It could be fine crackles or coarse crackles. Coarse crackles, think about opening Velcro. Fine crackles, think about Rice Krispies. Or if you rub the hair, rub some of your hair just beside your ear, you can hear a little bit of a fine crackling noise. But let's take a listen. Oh, let's see. Might be a delay. It's circling. Let me just check that it didn't open somewhere else. Oh, here we go.
Crackles are indicative of inflammation or infection of the small bronchi, bronchioles, and alveoli, which can cause increased fluid in the lungs. They can be described as either fine or coarse. Specific conditions
Oh, I accidentally paused you.
that
Sorry.
can cause this inflammation include pneumonia, pulmonary fibrosis, acute bronchitis, CHF, or acute respiratory distress syndrome.
Okay, back to our slideshow. Okay, and rhonchi and wheeze are actually the same thing as well. So rhonchi and wheeze, these are different from rails and crackles. Rails, crackles, you hear a little bit of a crackling noise, and rhonchi and wheeze are more musical. So when you listen for these, you know, it might be a high-pitched continuous noise, low-pitched continuous noise. Generally, the high-pitched noise is considered wheeze and the low pitch is considered rhonchi. So we'll have a listen to these ones as well. You might hear this in some of your asthmatic clients. Oh, this is a sensitive keyboard. Okay. Oh, here we go.
Wheezing can be auscultated on inspiration or expiration. It's indicative of a narrowed airway, either in the upper or lower portion. Specific conditions that can cause wheezing include asthma, COPD, lung cancer, or CHF.
And let's take a listen to some rhonchi.
Bronchi lung sounds are caused by secretions in the airways, most often the lower. The sound is often described as snoring. COPD, bronchitis, and cystic fibrosis.
Sorry, let me close that for a second. Okay, that was more music than you wanted. So our last abnormal respiratory sound happens to be stridor. Now, for stridor, you'll notice in can time that there is no box for stridor. If your client has stridor, you might hear hardly, stridor is the sound made when there is an obstruction in the airway. So think about choking, think about croup. If you start to hear this kind of high-pitched obstructed sound in your client's airways, it's really time for either Heimlich or the hospital. You're not going to sit down and note, hey, you know, my client has stridor. It's time for the hospital or Heimlich. So this is something that requires immediate attention and medical intervention if you come across stridor. So some of the interventions that you might be performing at home, many of them have to do with airway clearance. And so we would need to help our clients clear their airways, you know, if they have an inability to blow their nose or expectorate, if they have an inability to cough, or maybe they have a weak cough, or they retain a lot of secretions, we're going to need to help them. So here's some of the airway clearance interventions that you'll see at home. You probably help your clients with deep breathing, incentive spirometry, postural drainage, percussion, suctioning, cough assist, chest or vest percussion, oral care, and of course, medication. So here's a little diagram of some of the positions for postural drainage, usually used in conjunction with clapping or manual chest PT. And we are going to do a little overview of inhaled medications. So inhaled medications, they can consist of bronchodilators, corticosteroids, antibiotics, mast cell stabilizers like cromolyn sodium, if your clients take that. You'll often see them used with a spacer or an aero chamber or an opti chamber, whichever your clients may have, to help them bring the medication further into the lungs. You might see dry powder inhalers like discus, soft mist inhalers, liquid medication with a nebulizer, and oxygen also counts as medication. So we're just going to watch something for a second. Let's just get into our MDI with spacer video.
Please follow these simple instructions when using Aero Chamber Plus Flow View Chamber with face mask for your inhaler medicine. The chamber can be used right out of the package. Before use, ensure you have read the instructions for the chamber and metered dose inhaler. First, look at the chamber and make sure it is not damaged. If it is damaged, replace it immediately. Remove the cap from the inhaler. Shake the inhaler as per its provided instructions. Next, insert the inhaler in the back of the chamber. The Aero Chamber Plus Flow View Chamber includes a flexible back piece that accommodates all commonly prescribed metered dose inhalers. Apply the mask to the face, ensuring there is an effective face mask seal. The Comfort Seal mask is latex-free and contours gently to the face. The Flow View Inspiratory Indicator can be used to confirm a good face mask seal. Press the inhaler at the beginning of inhalation. As the Flow View Inspiratory Indicator moves forward, use the Flow View Indicator to help count breaths. It often takes multiple breaths for a child to inhale the medicine from the chamber. Only administer one puff at a time, following the instructions supplied with the inhaler on how long to wait between puffs. If you have any questions, please ask your healthcare provider. For complete instructions, please refer to the patient instructions available on our website.
Okay, I just want to show you something for a second. I'm going to put myself back on the big screen. So I think you can see me. And I just want to mention something about the aero chambers. So I hope that your clients are able to get at least 2 spacers and at least 2 inhalers of their medication. So hopefully they have at least 2 albuterol at home, 2 rescue inhalers, and they have multiple spacers at home, because I'm going to tell you why. So it is a good idea every week to rinse out and wash your spacers and inhalers if possible. You know, they can get a lot of gunk in them. They can get saliva in them, especially if you're using the mask. And I just wanted to mention that these do come apart. So this is an aero chamber that you might see at home. It comes apart in 3 pieces. So that's 1, 2, and 3. These can be put in a bowl of dish detergent in warm water. Wash, rinse with clean water, set to air dry. And it might take, depending on how humid it is, it might take overnight for these to dry. So it's a good idea to have a spare at home. If you don't have a spare at home, you know, I would recommend just wiping it, if you have like a barely damp washcloth, just wipe, the secretions out if you don't have a spare. But if you do have a spare at home, would be a good idea every week just to give them a wash, give them a rinse, let them dry overnight. This is another one you might see, Phillips Octachamber, also a spacer, similarly used, comes apart in 3 pieces as well. In this case, 1, 2, 3. They come apart the same way. Clean it exactly the same way. Put in a bowl of warm water with dish soap, rinse it out with clean water, set it to dry overnight. The next day when you put it back together, just make sure that it's all dry. And you really want to let it air dry too. You don't want to take, oh no, I have to take the medication now, but my air chamber is not dry. If you happen to grab a towel or grab a paper towel and you start rubbing it and you start drying it like that, beware if you use the aero chamber or the spacer right after you dry it with a paper towel or a towel. The moment your patient takes the medication, they spray the medication into the aero chamber. There is a risk that due to the static electricity created by rubbing the aero chamber clean, that you would, for example, pump the medication in, and then it would stick to the sides of the aero chamber due to static instead of going into your lungs. So I just wanted to mention that. And also for those of you who use a lot of these MDIs at home, sometimes the nozzle gets obstructed with medication itself. It can get pretty gunky in there. A lot of these inhalers, this for example is albuterol. The canister comes out very easily. Now this canister never gets washed. Keep this dry. Put it down, keep it dry. This plastic component here, it can be rinsed with warm water. Rinse it out with warm water underneath the faucet and to get rid of all of the residue on the nozzle that may build up, and set this to air dry as well overnight. The next day when you put it together, just give a spray to make sure that it's still working, okay? That it's working well. Now, some of your clients may have something like this. It's an MDI, it's an inhaler too, but this is Symbicort, for example. The canister, it does not come out. Even if you try to pull it out, you're like, doesn't feel like it comes out. This albuterol, this inhaler, for example, comes apart very easily. This one, it does not. And if you feel any resistance, chances are this is a type of inhaler that does not come apart. So what do? Every week, take a barely wet Q-tip, and you could actually go in there and just kind of wipe away the debris that might be inside there, right by the nozzle. And right after you do that as well, you can let it dry a little bit. You're using, of course, a barely damp Q-tip to do that. You want to make sure that your medication is working before you use the spacer for your clients again. Just give a quick spray and make sure it's working. I have to give 2. I haven't used this in a while. So I actually had to give 2 to make sure it was primed, working, and spraying again. So that's just something I wanted to mention quickly to you. And we're going to get back to the slideshow. I'm just going to go back into the computer screen, okay? All right, share the screen. Oh, I'm going to stop this for a second, share again. I'm sorry, I am not the greatest with computers. Trying my best. Okay, so now we're going to watch a little video about oxygen. And I apologize, I really wanted to do all of these demonstrations in person and do a little in-person show and tell. We actually do not have oxygen in our office for safety reasons, but I did find a video for oxygen just so that you can see how to crack open a tank and how to close it up as well. For those of you who come from the facility hospital setting, you may not have had the opportunity to do this in the hospital, but at home, we certainly crack open a lot of oxygen tanks.
All right, so in this next go, we're going to learn how to apply a regulator to an O2 tank. What I want you guys to keep in mind is these two notches right here coming out of the regulator. I call them teeth, and I want you to place the teeth inside of these two holes or gums. And there's really only one way to apply it. If you look all the way around the tank, no other side is going to have these two holes. And Maddie, when you apply this on, I actually want you to put it on incorrectly. But on the regulator, you're going to have a gauge that tells you how much pressure is going to be inside the regulator. You're going to have a flow meter right here to change the flow rate. And then we have quick connects right here for CPAP or anything like that. So go ahead and apply the regulator on.
Correctly?
Incorrectly. And then the third piece of equipment you'll need is going to be an O2 key. So just by looking at it, like sometimes it's like crooked, sometimes it's too low, and you think it's right. And if you were to continue tightening this and then open the tank, so go ahead and tighten it thinking that you're right. So she's tightening, she's tightening, she's tightening, she thinks she's in. Go ahead and take the O2 key, and then she's going to crack the tank. This is what you'll hear when it's not on. Go ahead and close it, right? So that's what you would hear if the regulator's not sitting properly on it. And so go ahead and you've reclosed the tank, and you're going to take the regulator off, and then you're going to, try it again. So you have the two teeth. You're going to put the two teeth into the gums. Awesome. And then go ahead and crack the tank. Great. And so now, when we look at the regulator, we should see the regulator's at a certain pressure. Right? So right now it's about 1100. Right? And now we have a fully pressurized regulator, and if we wanted to apply any piece of oxygen equipment, apply the tubing to this notch right here, and then you can adjust the flow rate all the way up to your designated rate. Right? And after you're done, you want to close the flow, and then you're going to lock the tank, so righty-tighty. And then if you want, you can depressurize the tank by applying your finger into that quick connect spot, and then go ahead and undo.
And so they just released the pressure from the regulator by pressing this quick connect spot. And a lot of people at home, they may not actually have this quick connect spot. What you might need to do instead, if you want to take the pressure out of the regulator, you want to just make sure there's no extra oxygen hanging around, is instead of pressing that little quick connect button that they have, what we can do to drain the regulator of any extra oxygen that happens to be hanging around the neck of the tank is you can actually go to your dial here where you select how much oxygen you want to deliver, and you could actually just bleed out the tank. So what you would do right now, they switched it off, but after you close up the tank, you could actually switch it, turn the dial to the oxygen back on. You'll hear a hissing noise of the oxygen escaping from the regulator, and that's fine. And once you don't hear any more oxygen coming out of the regulator, you turn it, to 5 or full blast, you'll hear a sound as the oxygen escapes. Once that sound finishes, you can turn it back off again, and you'll be sure there is no more oxygen in the regulator. The tank is closed. You can put the canister away for storage. So I'm sorry, I would really love to have you guys do hands-on to close up and open an oxygen tank in person. Video will have to do for now. But of course, in the future, if you have any questions for me, certainly call me up. You can come into the office. You can send your questions in writing for this session, and we'd be very happy to answer them. But really,
finger into that quick connect spot, and then go ahead and undo the regulator. And that's it. Good job. Thanks, man.
Okay, so that was the last of the videos. And I'm just going to tell you a little bit about some other treatments you might see at home for your clients. So positive airway pressure, this could be CPAP, it could be BiPAP at home. Some of your clients with obstructive sleep apnea, they might have CPAP machine at home. So when everybody falls asleep, you know, their muscles relax, and that includes muscles in the upper airway. So you'll see in this little diagram here, somebody has fallen asleep, their muscles have totally relaxed, and as a result, even the muscles in the upper airway have relaxed to the point where your airway has simply collapsed. And so here is this guy, here's the big tongue here, this is the airway, it gets blocked, and the air tries its best to make its way into the lungs, but it can't. And so what the CPAP machine is you put the mask on, and this machine, it pushes a fixed amount of pressure into your lungs, and it pushes past this obstruction. It's kind of like a splint of pressurized air. So the pressurized air blowing in, it technically acts as a splint, just enough to hold the airway open so that you can breathe in and you can breathe out. And how much pressure should be applied for a CPAP machine? That depends on what they find in the lab. Your client would go for a sleep study and they would titrate the amount of pressure in the lab. BiPAP is a little bit different. If you have any clients at home who have neuromuscular conditions, for example, maybe they have obesity, hypoventilation system, they need extra support in having their lungs fill up. So it's not really that they have a blocked upper airway, but they need a little boost to help them fill up their lungs properly. You know, they might have some weak muscles, you know, you might see some clients with some neuromuscular disease. And a BiPAP machine is a little bit different because it has two pressures. The inhalation pressure is larger than the exhalation pressure. So the inhalation pressure, it gives an extra boost to the client to help them fill up their lungs, gives a burst of air. And then when they exhale, the pressure goes down to their exhalation pressure. The pressure drops down and they're able to exhale. So CPAP and BiPAP, they're a little bit different, but CPAP requires your client to be able to breathe on their own. And BiPAP can be used for clients who are fully able to breathe on their own. They may just need a little boost of pressure to help them breathe. Or BiPAP can also be for some of your clients who may also need additional breaths. You know, BiPAP machines can also be set up for clients who need to be set up with the minimum amount of breaths per minute. So those are some of the positive airway pressure devices that you will see in the home. For more information, if your client cannot clear their airway despite all of the interventions we mentioned today, for airway clearance, for medication, for the positive airway pressure, maybe your client needs a trach. So these are some of the reasons why your client may need a trach. Tracheomalacia, anatomy abnormalities, upper airway blockages that cannot be resolved with positive airway pressure in the home, inability to swallow or cough, they have chronic aspiration, they may need respiratory support through mechanical ventilation. If you are interested in learning more about trach and vent, come to our trach vent training sessions. I'm going to get hold of our in-house teacher, Charlene. She is absolutely great, and we will be organizing some trach vent training sessions, and you do get contact hours for participating in these sessions, about 4 contact hours that are approved by the American Nursing Association. So thank you so much for all of your time, and please call me, drop in person, send along any typed questions. I'd be happy to answer them for you. I just wish I could do this all in person with you, but maybe another time when we don't have COVID, okay? So thanks so much for coming to my presentation, and I'm going to introduce our next presenters. We are going to have Courtney and Lisa do our next session in our training day. So let's see. I'm going to give up my spots. Thank you so much, everybody.
Thanks, Tracy.
Thank you. Thank you.
Hello, everybody. Lisa and I made a video for you to watch.